Joel, can you start off?
Yes, sir. Can you hear me?
Yes, Joel, I can hear you.
Yes, sir. So shall I start?
Yes, you can start.
Good evening, everyone. Welcome you all to the secondary section of ENT clinics and instruments. I thank Dr. Vasanth sir for his wonderful clinical discussion session on yesterday. If you missed it, do have a look. We have this series of sessions for the next 2 days, and I request you all to stay connected. Now, I request Dr. Vasanth Kumar sir to take over the session. Sir, please.
Yes, thank you, Joel. Good evening, all. This is our second session for the clinical discussion. Okay, yesterday we were talking about the clinical discussion about the ear cases. So today we will be talking about the nose cases. Hope you had revised most of the topics in the year as told yesterday. Yesterday I forgot uh, some of the important topics like the anatomy of the middle ear and other things. Just brush through that before going to the exams. Okay, and clinical discussion in the nose. Before going into that, let me tell you some important points. Please don't use any abbreviations when you are attending the clinicals. Like, for example, don't say it as JNA, say it as juvenile nasopharyngeal angiofibroma. What happens is sometimes the in due to what to say the anxiety or due to some psychological issues on seeing the examiner, we may tend to change the phrase, change the terminologies sometimes, okay, and we land up in problem, okay, which happened to me in the final year exam, okay. So rather than saying it as a what to say early ejection sorry end, I said EDM as a end diastolic murmur, which landed up with a big and I landed up in a big trouble. So never use any abbreviations when you are presenting the case histories. Yeah, as far as possible, try to switch to the expanded versions, okay. Don't say it as DNS, say it as deviated nasal septum, okay, and say your answers loud and clear so that the examiner can hear it. That should not, the examiner shouldn't think that um, he is murmuring or you are talking into yourself type, okay. So if you have in even if your answers are wrong, don't worry about that, just be loud and clear, okay. And if you don't know the answer, say don't know, okay, sorry sir, I don't know sir, because if you say that and if you say that, then he will go on to the next question actually. If you are going to bluff, if you are going to give a wrong answer, then again you are getting the trouble for you, because he is again going to frame a question from your answer till the time you are going to give the correct answer. So never do that. And don't argue with the examiner. If the examiner has some findings or any whatever it might be, if the examiner thinks if he is correct, let him be correct, because at the end we have to pass the exam. That is our aim, okay. So don't argue with the examiner. And keep your eyes and ears open for the clues. Some examiners give clues. Actually, the one who is listening gives you the clue. Most of the time our internals may be giving you many clues. So keep your eyes and ears wide open and just pick up those clues. Don't be dumb in uh, making out those clues, okay. And don't carry it away by the examiner comments. Whatever the examiner is going to comment on you, don't get carried away. You just concentrate on the case presentations, okay. So, and before case presentation, the clinical part and theory part is not entirely different. Both are more or less the same. So whatever the theory you have read is going to, you are going to present it as a case. That's all. You are going to correlate with that. So whatever the examiner is asking, he is going to ask something which you had read for the theory only. So it is not like theory is different and clinical is different. So don't have it in that mind, okay. Both are more or less the same, just that you have to what to say, uh, your answers should be correlating with the clinical scenario. That's it. So before going into it, please revise your anatomy, the basic anatomy of the nose or the ear on the throat. Okay. So don't commit mistakes in anatomical questions because that is considered to be the basics. Okay. So uh, you may ask, what are the basic, actually, what are the basic questions? That is a very, very difficult question to answer because I had many experiences in saying that whatever the questions for which you don't know the answer, the examiner will call it as a basic question. Okay. So even in post graduation exams, you may find this one. Okay. If you don't know the answer, if you are just staring at the examiner, then he will say, "Oh, such a basic question, you don't know the answer." Okay. So that happens with everyone. So don't worry about that. But anatomy is the basic. Uh, what to say, it's a basic question, so don't commit errors in anatomical questions. You should be well versed with the anatomy. Okay. Ear, especially the middle ear anatomy, and in the nose, some amount of microanatomy of the nose, and the other relevant anatomy you should be very well versed. Okay. And definitions, just mug up the definitions. There should be no don't commit errors in saying the definitions. You have to practice it one or two times. Okay. Those definitions which you had read, like the definition of cholesteatoma, the definition of OME, the definition of what to say, rhinoscleroma, rhinosporidiosis, and juvenile nasopharyngeal angiofibroma. For those things, never uh, say it in breaks or put your frame your own sentences, because those things which are given in the book as a definition is the definition. Okay, so don't try to change it. So practice saying the definitions. Okay, so that is going to help you a lot. Okay. And what are the causes? You might have a list of causes for everything, like any condition has many causes. So most of the examiners are very verbal in asking about what are the causes of this, what is the causes of that, what are the causes of that, like what are the causes of a purulent nasal discharge, what are the causes of unilateral nasal obstruction, what are the causes of bilateral nasal obstruction. So they may be asking many causes. They just want you to rattle some six to seven causes, just like that. So now, so don't hesitate in giving those things. So you have to know very well in advance. So those causes you might find only for very few conditions, and I think that will help you to score points. Okay. So these causes and differences between, like yesterday we were discussing about the differences between the furunculosis and otitis mastoiditis, and like that in nose also you have many differences, like the antroconal polyp and the ethmoidal polyp, or septoplasty and the SMA. These are very, very common questions that the examiner is going to ask, and don't commit mistakes in answering those questions. Okay. And so those things have, just go through it before in the morning of the exam. Okay. So just go through it, and don't try to what to say, bother about that. You will get it because you had already read it for the theoretical exam. So you you will be doing well. So do go with an open mind. Okay. And for the procedures, just practice the procedure with your friends. That will really, really help you. So get your friends and just practice uh, uh, don't crudely do the test and other things with your friends, but at least the normal things, like how to do a fistula test and other things, you can just practice with your friends. Okay. So before the exams, just keep in mind these simple things. It will help you a lot. Okay. And so coming to the, we are going to just go through what are the important things. I'm not going to tell you in detail as yesterday, because we are just going to brush up things, and from this, just note it down and go study for the clinicals in if for the next week. Okay. Just go through the topics. That's what I'm saying. These are the questions, and these are the probable questions you might be asked during the clinicals. Okay, so the nasal discharge, you have unilateral nasal discharge or the bilateral nasal discharge. Unilateral foul smelling purulent discharge in children is almost certain of foreign body in nose unless proved otherwise. Most of the examiners would love to ask this question. So in children, don't forget about a foreign body if it is a unilateral purulent foul smelling discharge. Okay, and bilateral discharges, you can see it in most of the cases like the deviated nasal septum, polyps, nasal allergy, and even in adenoiditis or adenoid hypertrophy. And blood stained, not the sputum, nasal discharge is in nasal discharge. If it is blood stained, then you have to think about the first one is juvenile nasopharyngeal angiofibroma or rhinosporidiosis or a malignancy. These are the three very common things. Don't miss it out. Okay, they present as epistaxis in the OPD. Okay, so what is the character of the nasal discharge will be also asked. uh, don't say it as the discharge was watery, say it as mucoid. That is will help you. Okay, watery means it is CSF. So if you are going to say it as a CSF, then you have to say it as watery clear fluid. Don't commit yourself as watery discharge. You can say it as watery or a mucoid discharge or a normal mucoid discharge. Okay, if it is purulent, then it is mostly, if it is infected, it is purulent. Okay, so nasal obstruction, there are many things for the nasal obstruction. Just remember the usual common causes which cause unilateral nasal obstruction and bilateral nasal obstruction. That's it. Okay, unilateral nasal obstruction, you the causes are given here. Just go through it. You have if you are asked about the question of say some causes of unilateral nasal obstruction, you have to just vomit out all those things. Okay, it starting from the deviated nasal symptom, inferior turbinate hypertrophy, concha bullous, or unilateral sinusitis. Unilateral sinusitis happens most of the time with fungal rhinosinusitis. Remember that. Antroconal polyp, which is unilateral foreign body, unilateral neoplasms, conal atresia, and trauma and rhinoscleroma. And for the bilateral nasal infection, most of the time it is an infective type. Okay, like the acute allergic rhinitis, chronic rhinosinusitis, atrophic rhinitis, vasomotor rhinitis, adenoid hypertrophy, okay, and ethmoidal polyposis, and sometimes neoplasm in the advanced stage, which happens, which crosses to the other side. Okay, and rhinitis medicamentosa too. So these gives you many list of questions. It's like if you say the causes, you should be ready for the next question from your answer alone, because you are going to uh, say about some 6 to 8 causes, and everything will be fired back. Like they can ask you about the vasomotor rhinitis. So for these things, I told those definitions which you are going to read really helps you. Okay. So if they are asking you what is vasomotor rhinitis, you have to just say it is an overactivity of the parasympathetic or sympathetic without allergy, which is more important. And you may be asked what is a Vidian neurectomy? What is the treatment of vasomotor rhinitis? Then it's Vidian neurectomy. And then what is atrophic rhinitis? They may ask you what is atrophic rhinitis, what are the theories of atrophic rhinitis, how the atrophic rhinitis are formed. Okay, and what is the classical clinical feature of atrophic rhinitis is the crust formation. And what is the treatment? What they are asking, what is the Eng's modified Eng's operation? So if you know what is modified Eng's operation, you can say that just complete closure of one of the nerves. Okay. And rhinitis medicamentosa. What is rhinitis medicamentosa? You have to explain it clearly. It is the unopposed alpha action of the decongestant nasal drops. Okay, and the how to, what is the treatment of rhinitis medicamentosa? You have to stop the medication. Okay, and rhinoscleroma. What is rhinoscleroma? What are the pathology you will find in rhinoscleroma? Okay, and what is the treatment of it? So these are very small topics. Just remember very few points. What is the disease, and what are the clinical features, and any significant, any classical clinical feature if it is there, just remember that, and what is the treatment to that. Okay, corneal atresia can be unilateral or bilateral, can be bony or membranous, which is mostly congenital. Okay, so how you are going to diagnose it? So we won't be able to pass the Rayleigh tube beyond the nasal cavity. Okay, so you can't pass the Rayleigh tube beyond the nasal cavity, then you can find the corneal atresia. Otherwise, how you are going to investigate it? We can do a CT scan. Okay, imaging can be done. Okay, and what is the treatment? You have to do a surgery. You have to make a open up the posterior corner, and you have to leave a catheter or a silicone sheath over it so that it doesn't fall back, it doesn't close again. Okay, what is Schluter's neuralgia? Those things are, that's what I told, those definitions are very very important, and you have to be well versed with that. Okay, just go home for now and just go through these things in uh, it will hardly take 1 hour. Okay, so because you had read for the theory, this is not going to take much of a time. So headache, in headache, you might be asked what are the types of headache, or what, how the sinusitis headaches will be. Okay, sinusitis headaches will never make the patient will never disturb the patient to in the during sleep. It doesn't come in the sleeping time, in night time. It usually starts after the day progresses. Okay, after the day progresses, it starts and builds up more during the afternoon time and in the evening, and then it comes to a settle. That's why it is called as office headache, because once you go to the office, you start the headache, the headache builds. Okay, so maxillary sinusitis, if the tenderness can be felt, the pain is more in the infraorbital region. The frontal, it is in the more in the supraorbital region. Ethmoidal, you might between the eyes, that is the bridge of the nose, and sphenoid, you find the headache in the retroorbital region. So these are the simple things which you say, the patient say clinically, so that we can easily recognize from where it is coming. Okay, and smell disturbances, it's very essential. Okay, smell disturbances, you might be asked about anosmia. What is anosmia, and what are the conditions which causes anosmia? Okay, and anosmia is nothing but loss of smell. Okay, and what are the conditions you get anosmia? You very well have one disease in your hand, just like that, for the last 2 years, killing the whole mankind. You can go with the COVID. And acute rhinitis temporarily can cause anosmia. It can be anosmia occurs due to the decreased airflow, bilateral obstruction to the olfactory pathway, reaching the olfactory pathway, and hence produces the anosmia. Okay, so those who are in the habit of using cocaine abuse, or the snuffers, they usually have anosmia. Okay, and atrophic rhinitis has anosmia because it is dry, and the crust formation would block the uh, smell going into the olfactory pathway. And parosmia, what is parosmia? It is perversion of perverted smell, which occurs in the skull fractures, injury, intracranial tumors, peripheral neuritis, and sometimes after streptomycin injection, they say, but I don't know, I had never experienced that. So you can say injury is a very common one in parosmia, and cacosmia is nothing but feeling of a bad smell. Okay, and hyposmia is decreased sensation of smell, and hyperosmia is increased sensation of smell, which you see in epilepsy, pregnancy, cystic fibrosis, neurotic psychosis patients. Okay, so these are the things where you have to um, uh, what to say, mug up some of the causes. So it is very easy to do that once, but don't just mug it up. Just know what is the relevant pathology behind it. It will help you in understanding. Okay, so the next one is the epistaxis. Epistaxis is a very virgin topic for all the examiners. They just come with so many questions in epistaxis. Once you say epistaxis, some may get even excited in asking you what are those. Because one, read about the Little's area, the anastomosis. Okay, what are the branches which come into that anastomosis? Okay, and Woodruff's plexus, what is Woodruff's plexus? Okay, it is in the posterior part. It is posterior, just posterior to the posterior end of the inferior turbinate. And what are the causes of epistaxis? You can start from injury, the malignancy, infective cause, granulomatous conditions of the nose. Okay, you can just enumerate what and what not. Okay, and management of epistaxis. Okay, anterior nasal packing, post nasal packing. Okay, so post-nasal packing is mostly done under anesthesia, general anesthesia. Sometimes nowadays we do post-nasal packing in the emergency setting with a Foley's catheter or with a post silicone catheter for the post-nasal packing. That can be tolerable by the patient, but solid gauze pack of post-nasal packing, the patient usually doesn't tolerate it when he is in the conscious state. Okay, so read about the epistaxis thoroughly. It's a topic of its own. You might have read it during your theoretical exam, but just brush it along when you're going. Okay, so coming to the examination part, you might land up with sandal nose deformity. Okay, so frog face deformity, potato nose rhinopima, or the depressed nasal bridge. Whatever the deformity is, saddle nose deformity, depressed nasal bridge, first you say it is due to the might be to a complication of the septoplasty. Okay, and frog face deformity. Anyone to answer? Yes, it is juvenile nasopharyngeal angiofibroma. Potato nose is otherwise called the rhinopima, and the depressed nasal bridge also is there. Okay, so that can happen in leprosy, tuberculosis, and many granulomatous conditions. Okay, and what is called a spatula test? Sometimes you may be asked to do a cold spatula test. If you don't have the spatula, the examiner may ask you to do. If you don't have a spatula, what are you going to do? You can do a cotton wool test. Okay, you can take a cotton wool and just place it in front of the nasal cavity, in front of the this side and the other side, and we measure the amplitude with which it is going to move and compare it on both the sides. So the air blast gives you an idea about the obstruction in the nasal cavity. If the left side is obstructed, the air blast is very less. Hence, in the cold spatula, the misting will be very less. Okay, so that gives you a clear idea whether it is a unilateral nasal obstruction or a bilateral nasal obstruction. Okay, and you might be asked about the dangerous area of the face and why it is known. Okay, because any infection in the dangerous area of the face can easily get carried away to the cavernous sinus because of the emissary veins. Because there is no valves in the vein, so it can directly spread to the cavernous sinus, which is deadly. So that's why it is called dangerous area of the face. And anterior rhinoscopy and posterior rhinoscopy. This picture I just uh, uh, showed you how to do a posterior rhinoscopy. Remember this thing for indirect laryngoscopy. Don't get confused with indirect laryngoscopy. For indirect laryngoscopy, you don't use the spatula. Okay, you don't use the tongue depressor. You hold the tongue outside with a gauze. You make the patient to put his tongue outside the mouth and then hold it with a gas piece, and then you put the mirror to see in indirect laryngoscopy. But for posterior rhinoscopy, the spatula is used to push the tongue downwards so that you get a space above and then see the posterior nasal cavity. Okay, nasopharynx and the posterior nasal cavity. So don't forget, posterior rhinoscopy is always done with a tongue depressor. Okay, so don't get confused with the indirect laryngoscopy and posterior rhinoscopy. So this question can be asked: septal perforation. Sometimes you may land up with a patient who has a septal perforation, but usually you get a patient of a deviated nasal septum only or a polyp. Okay, in the nose. Okay, so septal perforation. These are the causes: syphilis, tuberculosis, leprosy. You can take it as a package. So you can just say syphilis, TB, and leprosy, whatever the deformities and the perforation they cause inside the nose, and even the granulomatous diseases. There are many granulomatous conditions of the nose. If you say granulomatous conditions of the nose, be prepared to say what are they. Okay. And yeah, after it's a complication of a septal surgery can also lead to septal perforation. Okay. So the difference between the septoplasty and SMR, very, 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 very important question. Okay, just uh, mug it up. Once they ask you, just say you should be able to say that with 1.1, 0.2, 0.3, 0.4, 0.5. Okay, you have to finish it just in a moment's time, because this is a very easy question, and never uh, what to say, uh, do a mistake in saying this difference. Okay, so septoplasty is what we do nowadays. SMR, even I had never seen an SMR. Okay, it is a very radical surgery. It was done in the earlier days, but now we don't do it. Okay, it is not done in the, it can't be done in the children, and the entire septal cartilage we will remove it. Okay, so the flap, if you have to remove the entire septal cartilage, the flap has to be taken on both the sides, and the complications like septal perforation, saddling of the nose, everything is very tip deformity. Everything is very common with a SMR, but not in septoplasty. Okay, even septoplasty you can even do a revision surgery, but in SMR you can't do a revision surgery. So don't forget this difference. Okay, and same thing like a polyp and turbinate. The examiner may ask you how you are going to differentiate whether it is a polyp or it is a turbinate. He will ask you, you might be presenting a polyp was seen. A single polyp, large polyp was seen arising from so and so place and going this thing. But he may ask you, why can't it be a turbinate? Then you should be able to say, sir, no, I was able to probe it around and it was yielding to pressure. It was soft to touch. It was grayish in color, and it was insensitive to touch also. Okay. So if it is a turbinate, it will be sensitive to touch. It will be pink in color. It doesn't yield to pressure, and you can't probe around. Okay. So and another one thing I forgot to mention it one. If you are using any decongestion, then like any decongested pack is kept, the polyp doesn't decongest, but the turbinate decongests. It reduces in size. Okay. So those are the differences between polyp and turbinate. So these things you should be able to come up immediately. If you are able to say these things, your basics are done. Even if you are not answering any advanced questions, so they will be happy. Okay, chalo, this guy has answered the basic questions. So you may end up passing the exam. Okay, so don't commit these silly mistakes. These are basic questions which you ought to study. Okay, so the same thing like the ethmoidal polyp and the anthroponal polyp, you would have read it in your theory. I'm not going through that. Okay, so we had come mostly to the tail end of the presentation here, and I'll just say what are the topics to go and read again. Juvenile nasopharyngeal angiofibroma. Read about what are theories. Okay, what is juvenile nasopharyngeal angiofibroma? What is the histopathology? Okay, it has both the angiomatous component and the connective tissue also. That's why it is known as angiofibroma, the fibrous component and the angiomatous component. The very common thing is epistaxis of the patient, and it occurs only in the teenage group. So these things are very specific. So don't forget to mention those things. So read about the clinical features of the JNA and the management part. You surgery is the management, is the gold standard of management. You can do it either endoscopically or you can do it as open. If you are going into open, then you have to know about what are the approaches they use. The Wilson's approach over through the oral cavity, or the craniofacial approach which they are going to take. So just go through those things, and then medical management. What are the medical management drugs they use? They will be asking you. Okay, and for read about what is functional endoscopic sinus surgery. So what are the steps in functional endoscopic sinus surgery? Okay, to start with, it is a uncinectomy, and then they open up the middle meatus antrum. Okay, antrostomy, middle meatal antrostomy. Okay, and then going into the ethmoidal, anterior ethmoidectomy, and then posterior ethmoidectomy, and then sphenoidectomy. Okay, so then you go into the frontal recess and you see the frontal, open up the frontal recess also, so that the frontal sinus is also made patent. Okay, so these are the basic steps in the functional endoscopic sinus surgery. So if the examiner asks you, just tell him it's an uncinectomy, middle meatal antrostomy, and then you do an anterior ethmoidectomy, posterior ethmoidectomy, sphenoidectomy, and if there is a disease in the frontal, you go and address the frontal sinus also. Okay, and what are the complications of functional endoscopic sinus surgery? Okay, most of the time the examiner is expecting the orbital complication. Okay, any injury to the orbital fat is going to give you diplopia in the post-op time, or you can lead into a orbital complication, many orbital complications. Okay, can also if you injure the optic nerve, then you are going to take the vision of the patient. Okay, in the post-op period. So these are the very very important complications. So just don't get jump into it and say that, but classify it, the complications of the surgery, or the immediate complication and the late complication. Immediate complication, what and what are they, and the late complication, what are they? Okay, so we had discussed, I think, earlier in our presentation only. So just go through that. Okay, and inverted papilloma, differential diagnosis. Whenever you're going to give the diagnosis, you for a unilateral, for a polyp, don't give it as a polyp. Okay, you give it as differential diagnosis. I would then give the first differential diagnosis as polyp, sinonasal polyp, and then what it can be, it can be a inverted papilloma. Okay, these unilateral mass in the nasal cavity have to be given a differential diagnosis. Unilateral nasal up mass. Okay, they will be, the diagnosis is not a clear cut diagnosis. You have to give a differential diagnosis. If it is bilateral ethmoidal polyps, then you can say it is a bilateral ethmoidal or sinonasal ethmoidal polyposis. But if it is a unilateral mass inside the nasal cavity, if the case is a unilateral mass, then you have to have there is no way you have to give a differential diagnosis only. So the first differential diagnosis will be an antroconal polyp, but the second differential diagnosis can be an inverted polyp, it can be a rhinosporidiosis, it can be juvenile nasopharyngeal angiofibroma, so things like that. One, you have to say what, what are the clinical features that say it is a sinonasal polyp? What are the clinical features against it? What are the clinical features in favor of inverted papilloma? What are the clinical features against it? So you open up a discussion with the examiner. That is how you open up a discussion with the examiner. Okay, so inverted papilloma, that is, they may ask you what is Ringgold's tumor. Okay, what is Schneider's tumor or a Ringgold's tumor. So they usually ask the other terminology, so you should be aware of it. Then you should say it is an inverted papilloma. Then they will ask you what is an inverted papilloma. Then you have to say what are the definition of inverted papilloma and the clinical feature of it and the management of it. Management is nothing but a surgery, and they are expecting medial maxillectomy. That is the surgery. Mention that. If you mention medial maxillectomy, that's it, end of it. Rhinosporidiosis, read it in very detail, because every examiner will be having one or two questions on rhinosporidiosis, because it is very common in Tamil Nadu, in the southern districts, and most of them who, most of the examiners in their post graduation period would have seen many cases of rhinosporidiosis in their time. Okay, and uh, just go through what are the life cycle of rhinosporidiosis, what is the organism, whether it is a parasite, whether it is a classified as a fungus. Okay, and what is the clinical feature of it, and in the management part, what is the surgery, and what are the latest surgeries, and what is the complication in rhinosporidiosis. Never forget to tell the one of the complication is recurrence of the disease. Okay, even in inverted papilloma, recurrence is another complication. So for rhinosporidiosis, the latest we are using is the laser, the coblation technique, or a laser is used because you have to cautery the base. Okay, so till the time you don't cautery the base, it is going to recur. Okay, so what are the other places where rhinosporidiosis can occur? Okay, so it can even come in the larynx, it can come in the oropharynx, it can come in the oral cavity also. So those are the things, questions which can be asked from rhinosporidiosis, medical management of rhinosporidiosis. Very, very important DAP zone. Okay. So just remember the dosages also. And rhinoscleroma is another one. Okay. Just go through the theoretical part of it. Okay. You might be landing up with these questions. And I just showed an X-ray of the PNS waters view because it might come in your imaging or in your Vivo voice. Okay, so this is how the waters view look like. Okay, this is the frontal sinus, this is the orbit, and this is the nasal cavity, the septum. On either side, you have the maxillary sinus. Okay, and the sphenoid sinus is in after once you open up the mouth, you can see the sphenoid sinus. Don't worry about the rest of the structures because that and don't get too much of depth into it. Just know where the sinuses are. That's more than enough. Okay. And these are the simple ENT OPD instruments which they are going to ask you. Turrican's nasal speculum, Tilly's nasal dressing forceps, and this is the post nasal mirror. Sinclair Thompson's post nasal mirror. Don't mistake it for indirect laryngoscopy because this bend, this 45-degree bend is exclusive for post nasal mirror. In indirect laryngoscopy, you won't have this bend. It will be straight. It will be straight. Okay. And the mirror will be facing downwards. And another clue in postnasal mirror, the mirror is of smaller size. Okay. The small mirror will be of smaller size. But in indirect laryngoscopy, it will be of a larger size. Okay. So, uh, these are the basic instruments which I just kept for going into it. And don't commit any silly mistakes in the instruments. If it is a forceps, just say, if you don't know the name, you just say it is a forceps. Okay, that is more than enough actually. So we come to the end part of it. Any doubts or any questions, if you have, you can put it in the comment section. I will come back and reply you. And uh, do well in your exams. The clinicals is not a very big exam. It's not a very stressful exam also. Okay, go with the open mind, enjoy your clinicals, and go with the flow. Okay, don't get carried away by others who make you frightened saying many of the stories. Okay, just go with the open mind, do your exam well. I hope you guys will come out with the flying colors. Thank you.
Thank you, sir. Thank you for this session. It was really helpful, and thank you for sharing your experience with Viva in an examiner point of view. And we have our third session of ENT clinics and instruments by tomorrow evening, the same timing as 6:30 p.m. And please stay connected. And once again, I thank everyone for joining this session and see you all in the next session. Thank you all.
Thank you, sir.